they were all very different from our cephalometric norms. Peck and Peck in '83 were famous for some research they did on beauty queens. They also noticed that these beauty queens were very far forward of our modern cephalometric norms. We also know that the beauty queens, people with the most attractive faces, tend to have straight teeth naturally. If their teeth aren't straight, they're very easy to treat. They tend to stay stable. And if they're naturally well-aligned teeth, these teeth tend to stay well-aligned throughout their lifetime. They tend to have the more ideal occlusions. And of course, historical material, as I've alluded to, suggesting that modern faces are longer than the original, but the historical faces, the indigenous populations, the work of Plato and Zachrisson's ideal occlusions, Peck and Peck's beauty queens, all of these groups have cephalometric values that are very different from our modern norms, but are all very similar. They're all very similar to each other. And that makes me suspicious about cephalometric norms. It'll make more sense as we go through the presentation, but do understand where I'm coming from. The groups upon which we base an important foundation stone of orthodontics is scientifically weak. And if it's true that these groups, this foundation stone, is deceiving us, then it's very hard for us to see the wood for the trees. It's very hard for us to understand what's really happening if our foundation stone's wrong. And one thing we know is that if you look at cephalometric norms, there is a racial difference. Interestingly, the racial difference of the most attractive faces is very, very small. That intergroup difference is dwarfed by the intra-group difference. We should not forget this. But also, of course, the difference between the races is dwarfed by the difference between the sexes. A male skull is very different from a female skull. And this again is dwarfed by the difference in ages. We know when we are born, a third of us is skull, is head. And the craniofacial complex grows later than the cranial complex. So these are going out of order, changing the makeup and the shape of the skull. It's very easy to see a child's skull, the big eyes, small facial area, the large head. It's very different from an adult skull. And to be scientific, to be doctors, should we really be using a male adult cephalometric analysis for a female child? It doesn't really make a lot of sense, and it makes less sense to ask for cephalometric values of a different race while ignoring that factor. That seems somewhat silly. So we know that there is a strong genetic influence on the way you look, the way you grow. I mean, it would be crazy to suggest that's not true. But I think I've shown, and scientifically it's evident, that there's also a large component of the environment that's affecting how we can grow. Now, if there is this environment component, there appears to be, what might the factors be? Now, what we know is that syndromes like muscular dystrophy or similar syndromes can have a huge difference in the way faces grow. This individual, it was a girl, she's actually in occlusion. I mean, you can see her teeth biting together. And yet the distance between a Bolton norm, which we've already discussed, how normal is a Bolton norm, is centimetres. 5-6 centimetres of gross deviation in position away from norm, not even ideal. You could criticize this because this is a condition that's evolved or has been present in the child since a very young age, and syndromes may affect other things than the bone, although it's suggested this isn't true. Muscular dystrophy only affects the muscle, it doesn't affect the bone. So you could look at conditions that have a later onset. Here's someone who's fully grown, and he's grown to a good modern norm. He's not had any problems with that growth, although at this point in his life, when he gets married, he is starting, as you can see with the stick, to notice some problems with his health. And of course, it's Stephen Hawkins. He goes on to get probably some form of muscular dystrophy. We're not quite certain, because the normal forms would have killed him at this point in his life. Maybe he has a lot of drive. And his face just is warped. It almost looks like it's moulded to the shape of his headrest. He looks a little bit class 3. I don't know if there's a particular class 3 tendencies with these particular conditions. Of course, you could still say that that was a syndrome that may affect more than just the muscles. You couldn't say the same of strokes, cerebral vascular accidents. All that has happened here is a injury to the neural cortex has led to a decreased innervation in the muscular action of the facial muscles, causing gross dental and skeletal change, almost as if one side of the face is dropping down. Now, we can see that changes in the strength of the muscles seems to be making a change in the facial skeleton. Well, there has certainly been a change in masticatory effort over this time period I'm describing. Huge levels of wear were common, normal in our Paleolithic or even Mesolithic ancestors. It was usual to wear all the way through the teeth. In the older individuals, some 40 or 50 years old, it would not be uncommon to go through the furcation of the molars so that the separate roots would then function as individual teeth. This type of occlusal wear pattern, called a helicoidal wear pattern, was normal. It was normal to have working and non-working side contact. It was normal to have no cuspal interferences, no anterior disclusion, no canine guidance, not for, for 220,000 years minimum. This is how we're occluded. I wish a lot of TMD or gynothologists would really look at this and understand or take a viewpoint from that. Now, of course, what's happened? We've moved from a very hard, fibrous food that was very low calorific. We've moved to a very soft, high calorie food. It's estimated in North America now, most children could survive calorifically just from the drinks they take, meaning that they don't have to masticate at all. They could just drink things. My estimation is we've reduced our masticatory effort to possibly 1 to 5, possibly 3% of the effort we made, while our upper and lower skeleton is probably doing about 30% of the work of our ancestors. Our masticatory effort is probably 3%. And this change in food has come as we've needed less calories. We're doing less physical effort. We require less calories to survive. Now, you can artificially increase the muscle tone. Cole dissected monkeys, removing the coronoid process, placing it on the ascending ramus, so taking the temporal muscle and the attachment here, placing it here. He then took the masseter muscle running here and lifted it, sutured it over the top of this bit of coronoid and sutured it in the back of the ascending ramus. And what he found was a gross change in the facial skeleton. However, the mandible was generally unaffected. What seems to have happened is the small bones of the face have moved up and forward, which is the maxilla, and it's the bones around the maxilla have moved up and forwards. The most interesting thing is how little the mandible has changed. Now, the coronoid process have changed because he cut that off, so that would be expected. But generally, the mandible has changed very little. Although of interest is the position of the temporomandibular joint. So some very deep changes have happened. So the change in this muscular action has led to a change in the temporal bone itself, and almost certainly the saddle angle. Now, this is an individual who changed their mode of breathing. They gained a complete nasal obstruction due to some allergies that were undiagnosed for a period of time. Period of time this individual couldn't breathe out of their nose. By the time they could breathe out of their nose, they had established a habit of opening their mouth, lowering their tongue and breathing in this manner. Now, for most people, breathing is the most important thing in their life. Whatever other things or desires they may have, their next breath is obviously vitally important. And if you cannot breathe out of your nose, you will drop your tongue and open your mouth. You may return to having a clear airway. However, you may or may not return to having your tongue on the roof of your mouth and your lips closed. And there's a significant difference between those two responses. Now, experimental animals. Well, a couple I've mentioned already. Harvold, who was probably my favourite researcher. Unfortunately, I never got to meet Harvold. My father has. They got on very well. Harvold did quite a few experiments on primates. The most interesting, I feel, by far, was where he simply placed a piece of plastic sutured to the roof of the mouth so that the monkey could not comfortably keep their tongue on the roof of the mouth. This led to the monkey lowering the mandible and lowering their tongue to avoid this discomfort from this piece of plastic. Now, he had 18 control and 18 experimental monkeys. Every single experimental monkey developed a severe dental and skeletal malocclusion. The control monkeys had ideal occlusion, as primates nearly always do in a natural environment. And what I like about these two examples here is experimentally you've proved both things. You've proved that if you shorten the muscle and change its direction, you can cause the mandible to hinge upwards, with the small bones of the face being affected. If you posture the mandible downwards and the tongue, the mandible hinges open and the small bones of the face model downwards. Both cases, the mandible was largely unaffected. There were some changes in the cranium, but these changes were gained in one direction or the other direction. Now that is good science. That's something you can gain some understanding from. Of course, some suggesting that, of course, masticatory function is important. Changes in the mandibulolingual posture is important, so I've created this word to describe this postural change. And of course, the soft tissue balance, as I alluded to at the beginning, we know this. There's been a lot of research on breastfeeding, with a lot of people saying breast is best. It actually is one of the few areas within orthodontics where some large studies have been done, possibly not by orthodontists, but by the doctors looking at comparing breastfeeding to bottle feeding. And there doesn't seem to be a lot of difference between breast and bottle feeding. You would imagine with these large studies, even a small variation would become apparent. There's some studies show there's some difference, but not a lot. What I think we're likely to find more effect in is this change from a suckle to a swallow. I think that we're introducing soft foods, we're introducing food too early before a child would necessarily be able or would naturally transfer from suckling to swallowing. Before they've developed an actual swallow, food is being given to them. And this food is very soft, which is also an unusual situation. We have this concept that we don't want babies to choke and they need soft food. Now, we're giving babies food that's too soft, too early. They can't swallow, they attempt to suckle the food and they can because it's so soft. I have managed to suckle a Big Mac. It wasn't a pretty sight, but I managed to suckle the entire Big Mac. It was possible because it's relatively soft. Most baby food you can suckle, and I think individuals aren't making a full transition through. A suckle sucks the teeth in, and a correct swallow, you shouldn't see the facial musculature. This is well researched and well understood, we feel. Yet most people, when they swallow, you see them recruiting the facial musculature as a aberrant of a suckle, and this will necessarily place a force pulling in on the dentition. Now, these are the type of children we're treating. I think that we could imagine that hanging their mouths open with weak muscles, as we see in a modern environment, their faces will lengthen. I think it's less likely with the child here. I think he has looks like he has a stronger motor tone, and it's this combination of these two things that might be leading to the problem. But these children's faces will be growing downwards. There's a tendency for them to do that. Now, if you have strong musculature, and if you have your tongue on the roof of your mouth, then you're constricting the growth pattern. So your mouth is closed and you have strong muscles, it will tend to go forwards. And the growth will tend to be similar to this. And that will give you a long anteroposterior direction. If, however, you have a weak muscle tone and you have a low mandibulolingual posture, your face will tend to drop down. One of the bits of research that Bjork did was a comparison in identical twins in the growth direction of the maxilla, to which he found a 90% difference in the growth direction of the maxilla. The maxilla could either go truly horizontal or it could go truly vertical. Now, when a face grows downwards like this, a certain other change occurs. The mandible is remodeled so that it takes a more flat shape. And it's interesting that I've had several skiing accidents where I've been flung like a rag doll at high speed along a ski slope. Luckily, I've survived. But one of the important things that helped me was the fact that however much I moved my head around, at no point did my mandible hit my hyoid bone. That didn't happen. I think it didn't happen because of some good design. And the good design was the angle of the mandible shan't impinge upon the airway. And what is interesting is that the posterior facial height doesn't seem to vary very much, whatever distortions seem to happen. And that would be concurrent with the notion that this is protecting the airway. This area here is different. Now, why don't we see people whose faces have melted down and away? It doesn't seem so obvious. It seems somewhat hidden in the population. Well, Marcotte noticed that most people keep Nasian above Begonian. And they do that probably for psychological reasons. Do that for how you stand and present yourself to the world. And one of the things you notice about people whose faces have grown more vertically is the sloping forehead and the curvature in the cervical spine, because these individuals have simply raised their heads up until they have a normal presentation. But of course that will have curved their cervical spine, and it leaves them with a sloping forehead. Of course, we all have different shaped heads, so it's not always obvious when this occurs. Of course, what the net effect of this has been is a reduction in the horizontal dimension. Now, I don't think that mandibles are getting longer or shorter either from treatment or from this problem. What seems to be happening is the effective space, the dental space, is changing. As the mandible moves more vertically, as the angle increases, as it posteriorly rotates, whichever definition you want to use, or the vertical increases, the effective space reduces. And we're noticing this most, of course, in the posterior and the wisdom tooth area, and in the anterior, in anterior crowding, which is commonly what we're seeing within the population and the patients we treat. It's interesting to note that only 1,000 years ago, all of the skulls dug up in Scandinavia that had wisdom teeth had them working in function. There's been no time for a change in the genetic base in that period of time, not in Scandinavia particularly. And yet they now have common levels of wisdom tooth removal similar to most Western societies. Crowded teeth and impacted molars is commonly what we're seeing now. Now, I think the root of the problem that we're seeing is a change in the position of the maxilla that we're missing in part because of our cephalometric analysis. I think the maxilla is held up on the tongue and on the teeth. So the teeth biting together cause occlusal forces. So the more often the teeth are together, and the higher the force level when they are together, is causing an indirect action to hold the maxilla up, and then you have the direct action of the tongue holding the maxilla up. And when these systems are working, the maxilla moves forwards. When these systems aren't working well, the maxilla falls downwards. And in our modern society, we are all so affected, everyone, that it's very difficult for us to actually see what's happening. So we have the modern soft diet, nasal obstruction, leading down to a low muscle tone, an open mouth posture, which is causing this lowering of the mandibulolingual complex. It's down, and when it does come up, it's exerting less force. Now, the vertically maxillary development and tooth eruption